Thank you, Dr. Ravish.
Yeah.
Dr. Nandish, a few words from you.
Yeah. Very good evening to all the esteemed dignitaries present here. We are very thankful to Dr. Narayan Reddy, Uppi Narayan Reddy, for being the chief guest for this program. Our expert, Dr. Krishna Mohan, our speaker, Dr. Soumya Nagarajan, and Dr. Ima Matthew, for taking this wonderful session today. K-Samanvay and our esteemed leadership of President Dr. Ravi Shankar sir has become very successful program with all your involvement contributions. Let us enjoy the academics, learn from the experts here. So thank you very much for all joining today. Over to you, sir.
Good evening, everyone.
Shruti? Yeah.
Yes, sir. Good evening, everyone. It's my pleasure to introduce the expert for today's topic.
Shruti,
Yes.
1 minute.
Yes.
Basraj is there.
Okay, sir.
Basraj, please, few words, Basraj.
Yeah, thank you, Dr. Ravi Shankar. So, K-Samanvay is making a lot of academic noise, not only in Bangalore, across the India, with a great presence of our National President, Dr. Neelam Mohanji, our South Zone Vice President, Dr. Jose, and our North Zone Vice President, Dr. Devendra Sarinji. I'm sure the academics is going to be enriched with expert faculties like Dr. Soumya Nagarajan, Dr. Krishna Mohan, Dr. Hima, and with the one of the allergic past chairperson, Upin Narayan Reddy, is presence definitely will make a big difference. Thanks to Dr. Sumita, Ravi Shankar, Kushal, Shruti, and of course Nandish for taking the things forward with the carrying out all the academics. Best wishes. Thank you very much.
Thank you, sir. Thank you for the kind words.
Shruti, I will introduce our chief guest for this evening.
Yes, ma'am. Yes.
Before that, can I request Dr. Jose? Dr. Jose, are you there, sir?
Yeah, I am here. I am here. Some due to poor video, some issue with my video. So good evening. Sumita Naik Madam, and respected President of IAP Karnataka, Dr. Ravi Shankar, and Secretary Kushal Kumar, Treasurer Abhishek Pate, and the coordinator of the program, Dr. Nandish, and our own past President, Dr. Baswaraji, our IAP Allergy and Epidemiology Chapter National Chairperson, Dr. Upin Narayan Reddy. Today, the faculty, Dr. Krishna Mohan, Dr. Hima Matthew, Dr. Soumya Nagarajan, and Devendra Sarin, and all the senior members of the IAP, the national level, and our EB member, Dr. Priya. Good evening to all. First of all, I congratulate IAP Karnataka team taken the leadership to organize an excellent series of academics for benefit for all over India. And congratulations to Dr. Ravi Shankar ji and Dr. Sumita Nayak, Dr. Nandish, and Dr. Kushal Kumar, and everything for arranging an excellent academic fees and a series of specialty program they are arranging. And I think this today the topic is very useful for our general practitioners concerned. As you know, allergic rhinitis is one of the common allergy disorders in pediatrics concerned. There are a lot of dilemmas making diagnosis and making the ideal correct treatment part. There is a lot of confusion still existing in general practitioners concerned. And today the faculty under leadership of Dr. Krishna Mohan and Dr. Soumya and Dr. Himaventu going to enlighten all of regarding case with discussion on different aspects of allergic rhinitis. And of course, this will be a very useful program. I wish you all this program. Over to Dr. Sumita Naik for further proceedings.
Thank you so much, sir, for your kind words. It's now time for me to introduce our chief guest for this evening, none other than Dr. Upin Narayan Reddy, a good and an old friend of mine from Bangalore Medical College, who is currently the chairperson of the allergy chapter of IAP. He is the professor and head of Department of Pediatrics at the Shadan Medical College at Hyderabad, a consultant pediatrician and an allergy specialist. He was the ex-professor and HOD of the Department of Pediatrics at the Deccan College of Medical Sciences in Hyderabad. He has been a PG and a UG teacher since 30 years and has over 30 publications in the Index Medical Journal. A warm welcome to you, Dr. Narayan Reddy, and your opening remarks for this evening, sir, please.
Good evening, everyone. Thanks for introduction, madam, because it is a privilege to me. This is a very important topic, and it is underdiagnosed or unnecessary use of antibiotic, but unveiling hidden links for allergic rhinitis is a very important topic. And the main expert is Krishna Mohan, is a expert in allergy. He's a past chairperson to 2024. She's and speakers are Soumya and Hima. They are also expert in allergy diseases. This topic is very useful for pediatricians and general practitioners because most of the time it is an unnecessary use of antibiotic or their proper not diagnosed or inadequate treatment. That is very important. But it causes the burden, particularly it affects the quality of life, the suffering. Of course, nobody will die of allergic rhinitis, but it affects the quality of life. Child won't sleep, snores, goes itching, sneezing. Just it affects the sleep and learning, and parents. It affects the future life, academic also health also. So it is a proper diagnosis, proper management is very important to improve the quality of life. That is more important, particularly in children. So I wish all the best, and because best experts are there in the faculty. The Krishna Mohan, my good friend, because I worked under him as secretary treasurer. He was chairperson, and Soumya now is secretary. I am the chairperson for allergies after this year. So all the best for you. Thank you, madam.
Thank you so much, Dr. Narayan Reddy. Dr. Shruti, over to you for conducting the proceedings.
Thank you, ma'am. Good evening, everyone. It is my pleasure to introduce the expert for today's topic, Dr. Krishna Mohan R. He's a renowned pediatrician with European Certification of Excellence in Allergy and a certification in Advanced Vaccinology from CMC Vellore. He's a consultant pediatrician in Kerala and a national chairperson for Allergy Chapter IAP 2024. He's the director of DAAI course, Kerala. He is the editor for various journals, chapters, and textbooks. And it is an honor that you have joined us in for today's session, sir. Thank you very much for joining us. Dr. Krishna Mohan, may I request you to speak few words, please?
Yeah, at the outset, let me thank IAP Karnataka for giving this wonderful opportunity, and I congratulate them for starting this new venture at this a very, very useful academic program. So, most respected office bearers of IAP Karnataka, the national lobbies, as well as all those who are behind this wonderful program, especially my dearest friend, Dr. Sumita Naik, madam. So, she is a core team member along with me in the IAP WAC, and she is known to me personally for the last so many years, a great academician and a wonderful organizer. So, thank you so much, Sumita Naik, ma'am, for giving this wonderful opportunity. And the only doubt I'm having is that I'm kept as an expert, and the persons who are presenting the cases, that is Dr. Soumya as well as Dr. Hima, both of them are more knowledgeable and experienced than me. Of course, Dr. Soumya is the one who taught me immunotherapy a few years back. So I am very much honored for this. Thank you so much. Best wishes.
Thank you, sir. Thank you for the kind words. I would like to next introduce our speaker for today, Dr. Soumya Nagarajan. She's a consultant pediatrician, allergist, and immunologist. She's affiliated to Sanjeevani Specialty Clinic, Narayana Nethralaya, and Mallige Hospitals, Bengaluru. She's a secretary for IAP National Allergy and Applied Immunology Chapter 2026. She has publications in various national and international journals. She's part of the faculty at national and international conferences. She's a co-author for national guidelines on air pollution and asthma, cow milk allergy guidelines, and the editor for comprehensive textbook of allergy 360. Thank you, Dr. Soumya, for joining us in. It's our pleasure to have you here in this session.
Hello. At the utmost, I would like to thank Dr. Shruti for a very kind introduction. IAP Karnataka is my home team, and presenting on my home pitch is always a pleasure. And I would like to thank IAP Karnataka President Ravi Shankar sir and the other office bearers and Sumita ma'am for having given me this opportunity to present in K-Samanvay and under the presence of expertise of Dr. Krishna Mohan, Dr. Upin Narayan Reddy sir, and various other experts. So thank you so much for the opportunity.
Thank you, Dr. Soumya. I would like to introduce our next speaker for today, Dr. Hima Matthews. She's a senior consultant and allergist at Lissi Medicity, Kochi, Kerala. She's a faculty for Diploma in Allergy, Asthma and Immunology, a DNB teacher and thesis guide. She has contributed chapters in various allergy textbooks and published various articles in peer-reviewed national journals. Thank you, Dr. Hima Matthews, for joining us here today. Dr. Hima is here.
Dr. Hima? Yes, ma'am.
Am I audible? Sorry, ma'am, there was some
Yes.
issues.
Yes.
Thank
You
you.
can please share your presentation.
Yeah, sure, madam. Yeah, is it visible?
Yes, you can start.
Yes, ma'am.
Yeah. So first of all, let me thank everyone for this opportunity. I am so privileged to be part of this session. So I will be discussing two simple cases of allergic rhinitis. So this is actually a 6-year-old boy who is a second child of non-consanguineous marriage who was apparently normal till 3 months back. So now this child has presented with persistent non-productive cough for 10 to 12 weeks, which is worse in the morning and when lying down at night. So analyzing the symptom pattern, so the cough is often preceded by a tickling sensation.
Hello, Hima ma'am.
Am I audible, sir?
You're audible.
Yeah,
You're
yeah,
audible, but the voice is
you're
breaking
audible.
in between.
You can,
Voice
if
is
you,
breaking. Yeah,
if
one
you,
second,
Yeah,
sir.
you can
yeah.
switch off the video if you want for a few moments.
Ah, okay, sir.
Please go ahead, madam. Hima madam.
Yeah, sure, sir. So the cough is often preceded by a tickling sensation in the throat and frequent throat clearing. So the associated symptoms are there are intermittent rhinorrhea and nasal stuffiness, but there is no significant sneezing. And the child always complains of a sensation of foreign body or something stuck in the back of the throat. So there are no much triggers other than the symptoms which flare during changes in body position, especially in the reclining position. So there is no history of fever, no history of weight loss, or no history of breathing difficulty. There is history of intake of multiple cough medications, but only had very minimal relief of the symptoms with cough medications. And he had nebulizations with the salbutamol as well as levosalbutamol. And he was suggested to start on budesonide inhaler also, but the parents were reluctant to start on MDI. Then there is a history of shifting to a new house in the same locality around 3 weeks back, and there is no family history of atopy. On examination, the child was very active and playful, and there was Denny Morgan lines, which are the prominent creases under the lower eyelids, so which you can see here. But there was no allergic shiner or allergic salute. So as you know, these are the Denny Morgan folds, which we seen as a crease below the lower eyelid. And you have the allergic shiner is something which you see in the infraorbital area, which is a bluish black discoloration with a minimal puffiness, which is due to a chronic venous congestion due to the chronic nasal symptoms. And the weight and height of the child was maintained above 3rd centile. So on physical examination, the oropharynx, there was cobblestoning of the posterior pharyngeal mucosa with mucoid secretions in the back of the throat. So cobblestoning is something which is caused by the hypertrophy of the lymphoid tissue in the posterior pharynx. And the nasal examination showed a pale edematous nasal mucosa along with a hypertrophy, boggy inferior turbinates with clear watery nasal secretions. And the chest examination was actually normal with a normal vesicular breath sounds bilaterally equal with no added sounds. So what is the diagnosis in this case? So actually this is an upper airway cough syndrome, which is secondary to allergic rhinitis. So how will you classify allergic rhinitis? It is basically into intermittent and persistent. In this case, actually the symptom duration is more than 4 weeks. So we can classify it as a moderate to severe persistent allergic rhinitis. So we all know that the characteristic features of allergic rhinitis is there will be rhinorrhea will be there, itching will be there, sometimes nasal blocking sensation will be there. But allergic rhinitis can present simply as a upper airway cough syndrome also. So what is actually meant by an upper airway cough syndrome? It is a defensive reflex which is triggered by the interaction between excess nasal mucus and the sensitive structures of the throat and the airways. So how it happens? So there is an element of mechanical stimulation because we all know that whenever this post-nasal drip happens, there will be a lot of secretion trickling down from the posterior part of the nose, and this will irritate physically. So that causes a mechanical stimulation and cough. And there is a inflammatory exudate which is dripping from the posterior part of the nose. So that contain a lot of chemical mediators also. There is a chemical irritation. And whenever there is a continuous irritation of the posterior pharynx with a lot of secretions, the reflexes will be always, there will be a hypersensitized area there. So even a minor change like a dry air, a change in the atmosphere can trigger this sort of cough. So we have always seen kids who enter into an AC consulting room just start coughing, dry coughing, continuous bouts of cough, which is quite a common presenting scenario in our OPDs. And the positional variation is very characteristic because whenever they lie down or in the reclining position, you will get aggravation of the symptoms. So why that happens? So that happens because whenever the child is walking during the daytime, what happens is there is gravity which is acting. So they will be constantly swallowing down the secretions. But during the night, the swallowing is decreased. The gravity is not acting. So there will be a pooling of secretions which is happening in the posterior pharynx. Finally, it will irritate the cough. Similarly, at night, we know the climate will be there will be a little bit of dry, cold air. And whenever there is some indoor allergens, that will trigger the allergy and the symptoms. So what are the common symptoms we get in upper airway cough syndrome? So there will be a constant dripping sensation, the child will be complaining. There will be some tickle or scratchiness, frequent throat clearing, some globus sensation, the stucking something in the posterior pharynx or a foreign body sensation. You can get a frequent swallowing and persistent cough, which is not responding to common medications. Sometimes even halitosis as well as ear discomfort. So in this particular scenario, do we require any investigation? Actually, it is a clinical diagnosis, which is primarily based on history and supportive clinical examination. So the diagnosis you can confirm by a positive response to a specific upper airway treatment. So do you require any test? If possible, you can go ahead with a skin prick testing to identify the allergen. Of course, in this case, there is a history of 3 months. So definitely we are justified in getting a chest X-ray as well as a soft tissue neck lateral X-ray for adenoids. Even though for adenoid, X-ray is not the investigation of choice. DNA is ideal, but most of the time in our OP practice, we may not be able to perform a DNA. And spirometry and oscillometry, because usually the coexisting symptom which we usually get or the coexisting disease will be an asthma. So in this particular scenario, so serum Ig was elevated with a little bit of peripheral blood eosinophilia. AAC was 860. SPT was performed, which shows sensitization to house dust mite. The X-ray showed only mild adenoid hypertrophy. I think Dr. Soumya will be dealing it in detail. And the DNA was planned on follow-up if the symptoms are not improving. And the chest X-ray was normal. On follow-up, the oscillometry was also done, but there was no significant bronchodilated responsiveness. This child was started on mometasone furoate, the intranasal steroid, which is the treatment for allergic rhinitis, which comes under the category of moderate to severe persistent allergic rhinitis. And then a short course of second generation antihistamine, levocetirizine, was also added. Saline spray was also added, which will help to clear the secretions and allergens mechanically. And the sleep modification for 2 to 3 weeks, so that we get the effect of the intranasal steroids usually after 2 weeks after we start the medication. So till that, we have to manage the symptoms. So a little bit adjusting the position will help in reducing the symptoms. Of course, we have to advise the allergen avoidance measures also. On follow-up, there is symptom improvement, and we have to monitor the sleep quality as well as the school performance. So we can always consider allergen immunotherapy in this case. And the child was doing so well on intranasal steroids, and the option for sublingual immunotherapy was also offered to this child. Can I move to the...
I think we can have a very small discussion in between and then proceed to
sure.
next case. So thank you so much, Hima, for presenting a case which was, even though it looks very simple, it is very, very important in our clinical practice. So she has made the case as well as concept so abundantly clear that there are no more points to be added. But I would just like to reiterate some of the points that she has already, the history that she mentioned, everything she has told. So sometimes this upper airway cough syndrome is nothing but our old postnasal drip. It is a glorified version of our postnasal drip. So the history, even though she has presented this case as a case of chronic cough, sometimes the patient may not be reporting cough itself. Sometimes they will be telling a foreign body sensation, repeated throat clearing. That is a very, very prominent, sometimes that may be the only symptom which the patient will be presenting to you. The sensation of mucus in the throat, need to swallow repeatedly. So all these, she has beautifully brought out all those points. So those are all very, very important. And especially the character and the timing of cough is extremely important. So she has mentioned it will be a night cough, usually a night cough, which is usually seen after lying down, not the late night. When we are discussing asthma, we say the late night cough between the 2 a.m. to 4 a.m., which is more typical of asthma. It is a little bit different from asthma. The timing is different and the character is also different. So thank you so much for bringing that point. You can go to the next case. Dr. Soumya, anything to add? You can.
No, I think Dr. Hima has covered.
So please proceed to the next.
So can I move to the next case?
Yeah, please. Yeah, please.
Can we, there is a question on this case. Shall we take it now or shall we take it at the end?
Sir, I think questions you can take after the two cases, sir.
Okay, fine.
Okay, sir. Thank you.
Thank you.
Hima, please proceed.
Yeah, sure. Is my screen visible?
Your screen is visible,
correct.
but we are
still
on the first case. You take the second case.
Okay. So I think I have to reshare it. Sorry.
Yeah, please try that. Yeah.
Yeah. So going to the second case, this is a 5.5-year-old male child presenting with recurrent episodes of fever and cough since last 1 year. So briefly analyzing the symptoms, the child is having intermittent cough, which is explained by the parents as dry and wet. So episodes at a frequency of 1 to 2 per month, each episode lasting for 7 to 10 days, requiring nebulizations, and which are often triggered by colds. These episodes are triggered by cold. Then there are fever episodes, according to the mother, once in a month, which lasts for 3 to 4 days. Usually consult the doctor in day 2 of fever, and it subsides most of the time with antibiotics. So according to the mother, every 2 months they have to take a course of antibiotic. In the last 3 months, actually he took 4 courses of antibiotics. The symptoms were more severe. And the mother gave the history that there is, following fever, definitely there is a worsening of the cough. On leading question only, the mother told that there is nasal block, there is watery nasal discharge, which is more at night, along with an intermittent snoring, sleep awakening, and a little bit of nasal voice noted by the mother. There is no seasonal variation or triggered noted by the mother. So actually in this case scenario, mainly the mother was trying to explain about the cough and the fever. And these nasal symptoms were brought up only by asking leading questions. So as I already mentioned, no trigger to identify the mother other than exertion or viral infection and exposure to cold. And this child had one admission 6 weeks back, which is treated as pneumonia. The chest X-ray was normal except for a hyperinflation. And the labs at that time showed minimal neutrophilic leukocytosis with a CRP of 50 milligram per deciliter during the time of admission. He was started on budesonide inhaler in between. For 1 month, he has used the inhaler and it was discontinued as he got admitted with the diagnosis of pneumonia 6 weeks back. There is no history of atopic dermatitis or food allergy. There is no history of contact with the TB. There is family history of allergic rhinitis for both parents. And the child was vaccinated for age and flu vaccination 2 doses was taken 5 months back. On examination, the child was febrile with mild dehydration. There was no pallor, no clubbing. There was a few cervical lymph node palpable, not matted, mobile, non-tender, which is quite common in this age group because we get a lot of viral infections and URIs in this age group. So there was no red flag signs. Then weight and height was just above the 3rd centile. There was allergic shiner with a significant palmar keratosis and dry skin, even though the mother denied the history of atopic dermatitis. And on nasal examination, there was bilateral inferior turbinate hypertrophy with thick mucoid secretions. On examination, the child was tachypneic with a respiratory rate of 44 per minute with subcostal retraction. The breath sounds were decreased on left infrascapular and mammary area along with bilateral wheeze and crackles. So you can see the X-ray, a little bit the positioning, a little bit abnormal positioning, but still you can see that there is a little bit of mediastinal shift. The diaphragmatic ciliate on left side is obliterated. And you have got a hazy non-homogeneous opacity and the left lower zone. And the TC was 22,000, the polymorph 70%, CRP was 94. And as there was a history of fever with cough for last 1 week, I have done an immunoglobulin profile also. I was forced to do. So then it was negative. And the IgE was 980. The IGRA was negative. The MANDA was done from outside. It was negative. There was an echo also done from outside, which was also normal. So the question is what next? The present episode anyway, considering the clinical scenario, we have to treat as a pneumonia. So should I investigate this child for a recurrent pneumonia? So, but from the history, there is no serious infection. If we consider the Jeffrey model criteria or nothing like a severe persistent unusual resistant infections. And there are no radiologically documented pneumonias. And definitely there is some coexisting upper and lower airway symptoms. Even though the parents are more concerned about the cough. And it is a comparatively thriving child, 6-year-old, with both parents having allergic rhinitis. So what should be my working diagnosis at this stage? So I thought, why not it could be asthma with a coexisting allergic rhinitis? Because asthma coexists with allergic rhinitis is often the hidden cause of a recurrent pneumonia that is actually an atelectasis due to mucus plugging or because of persistent uncontrolled airway inflammation. Then comes the DDCS, immunodeficiency, cystic fibrosis, PCD, and tuberculosis. Of course, the IGRA and MANTO was negative, and there is no history of contact with the TB also. So the parents were counseled in detail about the need for further workup, and this present episode was treated with IV antibiotics, injections, ceftriaxone, nebulizations, albuterol. And after 3 days, after the symptoms got improved, chest physiotherapy and little bit of hypertonic saline and N-acetylcysteine nebulizations were also added. He was also started on saline nasal spray as there was significant nasal secretion. So as his symptoms improved clinically, and he improved clinically, he was discharged after 5 days. So usually in my summary, I usually write a plan of discharge because this child has come with repeated episodes of fever and cough. Of course, if we are not investigating the child in the first visit itself, we need to have a plan. So because usually what happens, recurrent episodes of cough, they won't be coming back to you for the next time. So the plan on discharge was to repeat the chest X-ray if the focal chest findings persist, to consider a bronchoscopy or CT if there is no radiological clearance, to consider further work if symptoms recur, and to start on MDI and INS, intranasal steroids on follow-up on trial basis if everything is going well on follow-up. So he was reviewed after 1 week. He had nasal discharge and night cough. Clinical examination was normal except for the nasal discharge, turbinate hypertrophy, and a minimal left-sided focal findings. So in that visit, I could do a F40, which showed a significant bronchodilated responsiveness. So he was started on MDI this time because the child already had budesonide. So then I thought I will start on formoterol budesonide combination and intranasal steroid mometasone furoate. Nautilus was also added for a short period. And after 2 weeks, when he was reviewed, he had significant improvement in the symptoms. Hence, he was followed up. And after 1 month, he was totally asymptomatic. You can see the X-ray, which was the first one is taken after 1 month. The other one was around 2 to 2.5 months after that, because it is necessary that we have to document a radiological clearance also in view of chronic symptoms. I could do a skin prick test also, which was positive for house dust mite blomia as a direct and parthenium. And the avoidance measures was counseled. And the child is doing well on low dose SMART and intranasal steroids after 3 months. So the diagnosis is very well could be asthma with coexisting allergic rhinitis. So we all know that this is a unified airway concept, or the one airway, one disease. The uncontrolled allergic rhinitis can significantly worsen the asthma, because allergic rhinitis, it is something which causes a systemic inflammation. And we have a lot of inflammatory mediators coming, which increases the bronchial hyperresponsiveness, which can also trigger the asthma symptoms also. And you can have mouth breathing whenever you have nasal symptoms. So the mouth breathing will allow unfiltered air to enter into your respiratory system. So that also can predispose to a lot of uncontrolled asthma-like symptoms. And there is something which we all know, that nasobronchial reflex, because something which irritates the nose through the afferent of trigeminal nerve, it can cause some sort of a bronchospasm, asthma-like symptoms through the vagus efferent in the bronchus. So that can also be triggered by this uncontrolled nasal symptoms. Of course, the postnasal drip can also add on to cough as well as the asthma flare-ups with possibility of microaspiration. So we all know that this uncontrolled asthma can mimic a recurrent pneumonia. So why? Because there is always a mucostasis, goblet cell hyperplasia. Thick mucus is formed with a low mucus clearance, creating a focus where the bacteria can multiply. And long-term uncontrolled asthma will result in airway remodeling. There will be basement membrane thickening, smooth muscle hypertrophy, which can cause a narrowed and damaged airways, which are more susceptible to atelectasis. Of course, there will be epithelial damage, which will break down the physical barrier, so which is easier for the colonizer pathogens to invade. This is yet another child presented with the same sort of presentation. So I think we, in this such a clinical scenario, we always have to consider a coexisting allergic rhinitis as well as asthma. So over to you, Krishna Mohan, for your expert comments.
Okay, thank you so much.
Stop sharing, madam. Yeah.
So thank you so much. That was a really wonderful presentation. And you have highlighted a very, very important point. Sometimes, at least sometimes, this is a very common clinical error, that is the children labeled with recurrent pneumonia. Often they will be having some underlying severe asthma, and the cause of wrongly diagnosing it as pneumonia may be due to some mucus plugging or atelectasis. We had, I think Dr. Hima herself has presented this as a case series, and we had presented it in CMC Vellore. She's having a series of cases of similar wrong diagnosis from elsewhere. So thank you so much for presenting that. And we should also remember, for the benefit of the audience, we should also remember, we have presented, the first case was a case of chronic cough, and the second case was a case of recurrent pneumonia. So when you start branding a case as an allergy of asthma, we should also remember what are the red flags where we have to think when you're getting a chronic cough or when you're getting recurrent asthma or pneumonia, what are the red flags of that? So Dr. Hima, can you please detail about what are the important red flags which we have to think for an alternate diagnosis?
Krishna Mohan, you mean for asthma?
Yeah, asthma, yeah.
Especially in the age group less than under 5 years, we have to be always careful while diagnosing, because the jnana diagnosis itself says that the second criteria is we have to rule out alternative diagnosis for
Yes.
especially in under 5 asthma. So when there is failure to thrive, when there is hypoxia, so when there is clubbing, then significant lymphadenopathy or recurrent infections, when they meet the criteria for immunodeficiency. So your history is much more important. History is the one which is more important. In both these scenarios, without much investigation, you can very well diagnose this case as a allergic rhinitis or allergic rhinitis with asthma.
Yes, yes. So you have made it very, very clear. So there are some questions related with this in the chat box. Dr. Sumita Naik has asked, what is the duration of intranasal steroids that is recommended for allergic rhinitis? I will take that question. So this is a often asked FAQ in many of our case presentations and conferences. Actually, we don't have any valid statement to say that this is the cutoff period for stopping an intranasal steroid. The only document which we can quote is the IAP Standard Treatment Guidelines, which was released in 2022. And it was telling we have to start the intranasal steroid and continue it for at least 3 months. And after 3 months, depending upon the symptom response, how the patient is responding to the symptoms, you can decide of stopping the intranasal steroids. There is no need of tapering. You can abruptly stop the intranasal steroids. So that is what is recommended. But unfortunately, many of the general practitioners as well as ENT people, we see the prescriptions continuing intranasal steroids for years together. That is not the recommendations. If there is good symptom relief, after 3 months, you can consider stopping intranasal steroids. And some other questions also in the chat box, Dr. Hima. Are leukotriene inhibitors helpful in allergic rhinitis?
Leukotriene inhibitors are not the treatment because we have to control the inflammation. So if it is upper airway, then it should be intranasal steroids and the inhalers. But it can be considered as an add-on therapy, especially in asthma with coexisting allergic rhinitis for shorter duration, because we all know that it is associated with a lot of side effects. We don't want to prolong the duration of that. So sometimes we may require, so in the beginning of our treatment. So it's not a long-term therapy, or it should not be used in isolation.
Krishna, there are one more question above from the beginning. Yeah. Why total IgE done as it is not required? Dr. S.P. Sethi.
So it is not required. It is not required. Just a supportive diagnosis. Actually, total IgE was done from outside. So sometimes the patient even requests, because I have to check. So such a case I am forced to do. But I would like to say that this is not something diagnostic. So if the IgE is normal, that doesn't mean that this is not allergy. But of course, if the IgE is high, it can suggest that it could be allergy. That's all. I totally agree with that.
Yeah. So Dr. Veena has asked, will you suggest immunotherapy in the second case?
The second case also we can suggest immunotherapy. But usually what I do is I will just try to taper off the pharmacotherapy. And I have to follow up the patient for some time, because I have to make sure that the patient will adhere to the treatment. Definitely, while tapering the pharmacotherapy, if the symptoms recur, it will be easy for you to convince them for the need for an immunotherapy.
Okay, very good. So somebody has asked another question, a practical question. Sir, what to do if running nose does not settle with citizen? Running nose is the only symptom on and off for 1 month.
Correct.
So definitely, if it comes, you can diagnose. If you are diagnosing it as allergic rhinitis, you can definitely start an intranasal steroid, and you can continue that till the symptoms subside. And such cases, if you do a skin prick testing and if you're getting a prominent allergen like house dust mite, that is a definite candidate for starting immunotherapy. He will respond to that well.
And if the nasal discharge persisting, not responding to oral antihistamines, definitely there is a role for DNE. So even the adenoid hypertrophy, adenoid hypertrophy alone can cause. So that could be the reason. So I think if it is so, then definitely you can go for with the help of a ENT specialist. The DNE has to be done, I think.
And sometimes there will be a lot of subjective variation also in response to symptoms with the antihistamine.
Yes.
Some patients will respond wonderfully to bilastine, but some others may not respond even. So you can try a change of the antihistamine also in between. So one last question, Dr. Hima, will you give intranasal steroid, OD or BD?
So in this age group, I have given only once daily. Once daily dose was enough. Usually less than 12 year, I start with a once daily dose only.
Dr. Jashwant has asked an important question, which is usually asked by the parents. Which food to avoid or what to consume?
Yeah, that is true. That's a very common question.
Yeah. So,
okay, fine. We know the answer. Okay.
Yeah.
Yes,
So which
yes.
immunotherapy is best? I think Dr. Soumya will be dealing with those questions later. I think all the questions you have covered. So as we are already 9:50, we can proceed with Dr. Soumya's case. Thank you so much, Hima. That was a wonderful presentation. Thank you. Soumya ji, please.
Yes, sir. So I think after Dr. Hima has set a precedence for the allergic rhinitis, just a couple of slides before we go on to the next cases. I think the allergic rhinitis, as our expert and my previous speaker has highlighted, it's a very common disease but very underdiagnosed. Presently, the ISAC one, which was done in India, puts the prevalence under in children under 6 to 7 years around 7%, and in adolescent close to about 25%. So I think it's a common misnomer, and this was one of the publications which was presented in CMC, where they feel that the watery runny nose has been the most commonest symptom with the nasal itching, followed by nasal obstruction and sneezing. So the common things we find in our OPD practice is how to differentiate between allergic rhinitis versus viral upper respiratory infections or a common cold. I think we have seen this flyer mostly during our COVID pandemic, but I think just to highlight that allergic rhinitis can be having a very clear, watery, persistent nasal discharge. Itching is the predominant symptom, which is not present in the other common viral infections or common cold. And we do have postnasal drip, as Dr. Hima has rightly pointed, and it is perennial, correct? It may be or throughout the season, exacerbations through the season and ongoing always. So there are some minor triggers which we can definitely pick up on history. So few of the common allergic triggers we see in allergic rhinitis includes dust mite, animal dander, cockroaches, pollen, molds, and foods are very uncommon as was being highlighted earlier. Going forward with our cases, we had a 6-year-old child who presented with persistent mouth breathing and nasal obstruction. Mother tells that this mouth breathing is predominant, and she tells that it's a constant nasal twang he talks with, and he's completely always having this blocked nose sensation. On probing, she says that the child had bouts of sneezing, mainly in the morning as soon as he wake up, and it becomes better as the day progresses. She describes that whenever he's sleeping next to her, he's a very noisy sleeper with teeth grinding. And the mother has been very concerned that she says that the older sibling is good, but this child has been kind of having allergy, always having this cold, persistent cold. And she has many times treated over-the-counter cold syrups as and when required, which has been very liberal. And the patient has been treated with various courses of antibiotics over the last 1 to 2 years, as much as 6 to 8 times in a year, but with not much relief of the symptoms. Mainly, again, the school complaint has been that he has little sleepiness during the day and in school, which is affecting his school performance. And this has been the concern flagged by his class teacher. Again, mother tells that teeth grinding is predominantly there and snoring at times is there. Going on to the family history, the child has parents having both allergies. Mother tells that she has asthma and father has allergic rhinitis. On probing for the environmental triggers, the mom says that the father smokes cigarettes, but not at home, outside, but he comes back home. She's also tried various other alternative medications for the child's treatment, but with little benefit. There are no pets at home. On examination, he was a thin child with weight and height both below the 25th centile. He had a marked bilateral inferior turbinate hypertrophy, which has been described by Dr. Hima, which has been leading on to a complete obstruction, what we see on the anterior rhinoscopy. It is very important, especially when we are when we are thinking about any nasal symptoms or chest symptoms, always look up at the nose, because many a times we miss this important finding. He had typical adenoid faces, which I'll come to in the couple of slides later. The rest of the examination was non-contributory. So based on the ARIA classifications, as Dr. Hima was also mentioning, which we commonly use to classify any patients with allergic rhinitis, this child has more than 4 days a week symptoms and having abnormal sleep affecting the school activities and troublesome. He falls in the moderate to severe persistent allergic rhinitis. So how can we proceed further? So investigation, should we do anything? So because the constant concern was the nasal blockage and the snoring, though the nasal endoscopy is an forte of ENT or few of the practicing allergists, but I think one investigations when this gold standard is not possible is getting an X-ray lateral neck. So just to give an highlight that we can definitely see the adenoid shadow against the lateral X-ray when we see against the air column behind the nasal passage and the soft palate which we see. And based on the adenoid hypertrophy, we can see that there is mild or moderate or severe obstruction which can obstruct the airways, which leads on to this nasal obstruction and also give rise to other comorbid factors such as sleep disturbances or obstructive sleep apneas. We did a gold standard for adenoid hypertrophy, which is the nasal endoscopy, though it may not be mandatorily done in all patients with suspected adenoid hypertrophy. He had a very large adenoid hypertrophy, which is being highlighted by the arrow against the lateral wall, which shows almost complete obstruction of the nasal passage. So this patient has moderate to severe persistent allergic rhinitis with obstructive sleep apnea with adenoid hypertrophy with faltering growth. The few questions I think I thought which would be very practically approachable is whether the factors which contribute to allergic rhinitis and obstructive sleep apnea are common, and is the same pharmacological options could we be considering? And the other question is very commonly as pediatricians we get asked is in such cases should we be considering adenotonsillectomy or adenoidectomy? And I think allergic rhinitis and obstructive sleep apnea often coexist with a common symptom of nocturnal dyspnea. So I think most of the kids may have normal growth, but can also have failure to thrive or could be overweight also. So most of them tend to have adenoid or tonsillar hypertrophy also. Yeah. So this is a typical adenoid faces where we see the long face, open mouth, constant mouth breathing. Sometimes on examining, we see that high arched palate and dull facial expression, sometimes rhinorrhea. So typical adenoid faces, I think, would also be one of the clinical clinchers when we are examining the patient. Adenoids form a part of something we call as Waldeyer's ring, which forms a rich source of lymphatic tissue along with the tubal tonsils and the palatine tonsils and the lingual tonsils. So adenoids actually act as the gatekeepers of our immune system and are very much important in developing the primary and secondary immune response. So all immunologically healthy children do have adenoids, and we see this peak growth not sometimes at 4 to 5 years, a little earlier, 2.5 to 3 years. And by about 9 to 10 years of age, natural atrophy happens. But during the peak growth also, if they have underlying allergic rhinitis, adenoid hypertrophy also adds on to the burden of the allergic disease. So there are absolute indications of adenoidectomy in children. Especially we see that if they are having obstructive sleep apnea, not responding to the pharmacotherapy in the form of intranasal steroids, recurrent otitis media, which are non-infective, and recurrent sinus infections having severe impactment of the facial development. I think these are the only absolute indications we may think about adenoidectomy. Otherwise, I think we usually try to have conservative management with intranasal steroids. And because intranasal steroids has a two-pronged approach where it can also treat the allergic rhinitis, and it also helps to reduce the size of the adenoid hypertrophy and thereby giving patients symptomatic relief. And this patient, we also had started on intranasal steroids and second generation antihistamines for 2 weeks. We stopped second generation antihistamines and continued with intranasal steroids for a period of 3 months. And he underwent an, I'm sorry, here skin prick test reading is missing, that he underwent a skin prick test and he was co-sensitized to house dust mite very strongly. And because he had symptoms of allergic rhinitis since many years, moderate to severe persistent symptoms, and there was recurrence of symptoms after stopping intranasal steroids, he was started on allergen immunotherapy for house dust mites, and 6 months after follow-up, he is doing much better. So I think it's important that we address comorbid factors with allergic rhinitis, which adenoid hypertrophy is a very common finding which we see in our pediatric practice. Dr. Krishna Mohan?
Yeah, I'm here. Wonderful presentation, Soumya. You have covered everything, and that is a very important topic also, very common in our clinical practice, not only for allergy specialists, but in our day-to-day practice. Majority of the cases that we see may be having an underlying adenoid hypertrophy. Only one point which I beg to differ in my clinical practice is that I never do this X-ray. So if you have a nasal endoscopy available, why should you go for an X-ray? Because it will just give you an extra radiation dose, and
Correct.
it will never give you the percentage of choanal obstruction. If for adenoid hypertrophy, our main aim is to decide upon surgery. So until and unless we get that percentage of choanal obstruction, we won't get. So in my personal practice, I never do that. I don't know, but maybe the recommendations are still there. But endoscopy, if available, that will be always
Definitely.
the best.
Absolutely, agree with you. The gold standard for the adenoid hypertrophy is nasal endoscopy. Sometimes, not all of us may have access to the nasal endoscopy, or the parents may be a little reluctant to go to the ENT initially. I think just to, probably if we do not have access immediately, and if an X-ray can be done initially, and if you can give a trial of treatment, I think it was only for that I just highlighted. But absolutely agree with you that nasal endoscopy is the gold standard for the diagnosis of adenoid hypertrophy.
Okay. So I think we can take the questions at the end. You can proceed to the next case.
Yeah, I think this is a shorter case, and but a very important comorbid condition again. This was an adolescent girl I saw with incessant sneezing since the last many years. Again, mainly in the night and early morning. However, in the last, and this she has been taking on and off oral cetirizine as and when required with minimal relief, and its symptoms come back. But the concern, which again was in the last year, on and off, she's been getting itchy, red, watery eye. She again has a history of rubbing her eyes very vigorously, And of late, she's telling that it is causing her blurring and some visual concerns. She has been seeing the doctor locally, and before seeing also, she has taken topical antibiotic or steroid eye drops from the pharmacy and used it by the mother with minimal relief. But when she's been seeing the primary care physician, she has been advised on topical steroids for a longer period of time, or she's required topical antibiotics, being treated this as Madras eye episodes or allergic conjunctivitis, infective conjunctivitis. Now, I think her main concern was the persisting eye issues, which they thought because none of the medications were helping. On probing the history that she has a dog since she was a baby, but never had symptoms. Again, many were telling that the dog may be causing the symptoms, and she's very anxious about separation. On examination, she had a hugely enlarged boggy inferior turbinate hypertrophy. She has dry skin, probably a little, she has been having itchy dry skin also, probably could be an underlying mild atopic dermatitis also. But on examining the eye, I think she has this giant papillae, which was there at the limbus of both eyes, and cobblestone appearance under the upper eyelid, which was very suggestive of an ongoing allergic etiology in the eyes. And the ear and throat examination were unremarkable. So here we thought that child is having allergic rhinoconjunctivitis with severe eye disease, and she was co-managed with ophthalmologist for the visual disturbance evaluation. So I think it's important that when we are having patients with allergic rhinitis, always keep association of comorbidities in allergic rhinitis as the open forum, because I think allergic rhinitis per se has lot of comorbidities, and allergic conjunctivitis is a very common occurring factor with allergic rhinitis. And the role of intranasal steroids in optimization of allergic rhinitis and conjunctivitis in this child, and should we be using topical antihistamines, and any role of allergen immunotherapy were the questions I faced when I saw this patient, how to go forward. We started this child on intranasal steroids twice daily and second generation antihistamines once a day for 2 weeks. Her symptoms got better, and we stopped oral antihistamines after 2 weeks and scheduled for a skin prick test because of her persistent symptoms with the continuation of intranasal steroids. Here, she showed sensitization to dust mites and dog epithelia. She was advised appropriate avoidance measures, though she was not ready to separate with her dog. And the ophthalmologist confirmed the presence of keratoconus, which is one of the complications of eye rubbing in allergic eye disease. And she was advised topical antihistamines for a shorter period of time under the monitoring of ophthalmologist. She was better, and the intranasal steroids was continued for 3 months, and she was concurrently also started on allergen immunotherapy for dust mite. 3 months on follow-up, she's doing very good with control of both the eyes and nose symptoms, hence her intranasal steroids was stopped. Her quality of life has definitely tremendously improved, and her quality of life, especially the swimming where she was doing, was concerned because it was irritating her eyes. So I think just to wrap it up, allergic rhinitis is not as simple as we see. It has various comorbid factors such as asthma and upper airway cough syndrome, as highlighted by Dr. Hima. We should also keep in mind conjunctivitis, otitis media, or adenoid hypertrophy with a lot of secondary involvement such as having the impairment of quality of life, and it leads to a lot of issues in day-to-day practice. So with that, I open the forum for the expert comments and any questions.
Thank you, Dr. Soumya. That was a wonderful presentation. So before we go into the chat box, some comments and some doubts. So regarding allergic conjunctivitis, especially VKC, what is your personal experience with allergen immunotherapy?
So with only VKC, I would not venture into allergic immunotherapy because the level of evidence recommendation for only vernal keratoconjunctivitis is very low. If the patient has associated allergic rhinitis, with optimization of the pharmacotherapy for the same, and if we have sensitization, they respond nicely for allergen immunotherapy, and the level of recommendation is very strong.
I think the allergens also are distinct when we see the allergic conjunctivitis. It is more of pollens and rather than house dust mites alone, isn't it like that?
Yes, probably pollens also could be predominant. Again, in my practice, maybe skewed because of referrals, but I also see a considerable amount of house dust mite sensitization, and they do well with immunotherapy if there is underlying allergic rhinitis.
Okay. I think Dr. Hima is having a series of cases of this thing, conjunctivitis, including VKC. Can you add something, Dr. Hima?
I totally agree with Dr. Soumya. So VKC alone, there is no much role. And more than pollen, even the house dust mite is the most common allergen. And the immunotherapy role for house dust mite immunotherapy is there when there is coexisting allergic rhinitis.
Okay. So the benefit of the audience, I will say that there is one series of lectures on allergic conjunctivitis in the allergy chapter website, a 3-day program. I will share the link with Dr. Sumita Nayak, madam, so she can share with the participants. Okay. Dr. Soumi, I think there are some more doubts in the chat box. Can we take that?
Yes.
Krishnamon, I will ask the question because some questions are missed.
Yes.
They will message me personally, why didn't ask us? So let me finish it up.
Please ask. Please ask.
Treatment guidelines for allergic rhinitis with allergic conjunctivitis. It is the same or something we had to add because both are there. Allergic ER and AC both are there. Soumya.
Sir, I think it is important that when we have allergic rhinitis with conjunctivitis, we always optimize the treatment of allergic rhinitis. And as earlier speakers have said, the mainstay of treatment is intranasal steroids. And once the turbinate hypertrophy reduces, it has definitely an indirect benefit for the allergic conjunctivitis as well.
Okay. A lot of accolades to both the speakers from a lot of people, Rashmi and everybody else. So any role of Montelukast for adenoid hypertrophy?
Sir, it is one of the probable indications which is there for Montelukast, but the level of evidence is very less. So we still prefer second generation antihistamines and intranasal steroids rather than Montelukast, which is the second line of treatment.
So Sangeeta is asking, is a child has adenoid hypertrophy with only symptoms of snoring, no history of sleep disturbances, failure to thrive allergic rhinitis, is there a role of INS?
Yes, sir, definitely. I think the recommendations, the treatment recommendations do say the intranasal steroids to be given for at least 4 to 8 weeks and to see how the patient responds. Generally, the adenoid hypertrophy, the symptoms of obstruction definitely come down. Even in the absence of allergic rhinitis, we can use intranasal steroids.
Okay, good. And Dr. Samira is asking, from what age can immunotherapy be started?
The current recommendations is above 5 years of age, sir.
No, Hima also can answer. I'm not just asking Soumya. Hima, you also can answer.
No, sir, actually, Dr. Soumi and Krishna Mohan are my mentors.
Okay.
There is no mentor, there is no expert here, sir. The expert is
my
forum is open.
Okay. What can teeth grinding be attributed here, ma'am? She's asking somebody iPhone. I don't know what that.
Sir, I think
in your first case, you told teeth grinding was there.
Yes, sir.
Soumya.
Yes,
Remember?
sir.
Yeah.
Yes, sir. Yes, sir.
Yeah.
So generally, patients with adenoid hypertrophy and obstructive sleep apnea, the teeth grinding could be because sometimes when they are sleeping, hypoxia, this can lead on to teeth grinding, and then the stage of apnea goes on. So teeth grinding again is a very hallmark feature of obstructive sleep apnea.
Okay. So same question is repeated. The role of Montelukast, which you already answered. Krishna, can pediatrician do OPD-based nasal endoscopy? Is there any training program?
So in majority of our parallel training programs, the 1-year programs of allergy that we give a half-day workshop on this endoscopy also. And it is not that difficult to do. If you can purchase the machine also, if anybody is personally interested, they can message to me in WhatsApp. I will give the details regarding the machine, which machine to purchase. Dr. Mitesh in Ahmedabad, he is doing very often. He is doing.
Even I do nasal endoscopy.
Yeah, it is not that difficult to do, because I am not doing in my personal practice. I married a ENT surgeon years back, and she is doing that.
Sir, you're making sure the OPD is full there.
Okay, good. Okay. So Neetu is asking, even Hima also can answer. For second case is okay for you. For second case, SCIT or slit better, since she is having allergic conjunctivitis causing keratoconus.
Sir, I'll take
Hima,
that.
Soumya, yeah,
Yes,
you
sir.
take.
So generally, I think the question we get asked about different routes of immunotherapy regarding subcutaneous or sublingual, there is no major difference between the route of administration. So I think if depends on the patient, but generally we are more skewed towards sublingual immunotherapy because it's more safer and the patient can take it at home. And the chances of adverse effects with sublingual immunotherapy are probably minimal to none.
Yeah. Shruti, you want to take up the question? You want to, Izo?
Yes, sir.
Shruti?
Yes,
Vilayat is asking, okay, please start. Take from Vilayat. Can you
Dr.
please?
Vilayat wants to know there's any update in age criteria for which intranasal steroids are used. Any update on that one?
So generally, can I take that question? Dr. Hima, you would want to?
No, sure, madam. Please go ahead, Dr. Soumi.
So the current recommendation is 2 years and above, where we can use intranasal steroids. Fluticasone furoate is recommended about 2 years of age. Mometasone maybe 4 years and above, but the safety and bioavailability of fluticasone is well established, and above 2 years it is recommended for usage.
Yeah. Okay. Thank you, Dr. Soumya.
Can I ask one question?
Yeah, yes, ma'am. Yes, ma'am. Parvati, ma'am. Hi.
I am
Madam.
Parvati. I am Parvati. Krishna Mohan and Hima are both my students. And
Sumita ma'am and
daughter,
Ravi Shankar sir. Parvati madam is my first pediatric teacher. She is the one who taught us everything on pediatrics. Thank you, ma'am, for being
mine
with us.
also.
Welcome you.
Yeah.
Sorry, we didn't recognize you. Sorry for it.
Sorry, 1 minute, just 1 minute. And
please, madam.
their classmate, Anjali is my daughter. My daughter Anjali is their classmate, and his son is having allergic rhinitis. And my husband is ENT surgeon, and that nasal endoscopy was done. It's normal, nothing to worry. And we are planning for immunotherapy. So I'll take him to either Krishna Mohan or Hima one of these days.
Thank you.
Thank you. Nice discussion. Well,
thank you so much. Thank you so much.
Thank you.
They will be in good hands, ma'am. He will be in good hands under their care.
Yes.
Shruti, go ahead with the next question.
We have another question. How frequently can we repeat the course of intranasal steroids? Dr. Hima, do you want to take this?
So how frequently we can repeat? So after, as Krishna Mohan has already mentioned, because after 3 months we may have to discontinue in some cases if the symptoms are well controlled. So if we have to continue, we have to analyze the cause for that. So we have to work up for any allergen exposure and all, and then we will have to decide for a definitive therapy like immunotherapy. So then sometimes there is a concept that then there is seasonal flare-up of symptoms. So in that case, maybe we can try up that pre-seasonal for a few weeks. So minimum 2 weeks duration is required for the effect to come. After that, we can decide on maybe for 6 to 8 weeks or 12 weeks therapy till that allergen exposure is over. So that depends upon the symptoms, how severe it is, and the duration, etc.
Yes, there is no definite cutoff. As Dr. Hima said, there is no such definite cutoff. If the symptoms are not getting controlled, you can restart. Restarting intranasal steroid in a case of allergic rhinitis doesn't mean that you have failed in the treatment. So it is any allergic disease, there will be relapses and all these things. So you can anytime you can restart.
Shruti, next question. Yeah.
I think we've pretty much covered all the questions.
Okay.
Somewhere Previously, I think somebody had asked which immunotherapy is best. Have we covered that?
No. Basantappa has asked one question that we missed it. Two questions we missed it. That I will.
Yes.
I will take that. I will just go up. Yeah. White total light. Okay. How long we need to give nasal steroid spray, madam? Basantappa, I think that question is answered.
That was answered.
Yeah. That question is. I think almost all questions are taken.
Vande, sir. I think Dr. Shiva Prakash has asked which immunotherapy is best.
That she answered. Slit is the one.
So just to conclude on immunotherapy, I think the level of evidence for immunotherapy for house dust mite and pollens is very strong. And for molds or other cockroach or pet dander, the level of evidence is not much. So generally, we go back on the history and decide about going ahead with immunotherapy.
Thank you. Thank you for that clarity, Dr. Soumya.
So one important thing we always see in our practice is the attachment with the dog. We know the dog is causing the allergy and they are not ready to give up the dog at all. They'll go on changing the doctors are asking for the more treatment, steroids and everything like that one. Really, we don't know. Mohan, do you got any idea how to separate them? Anyway,
No,
what do you do in your practice?
Especially for the dogs, the only thing that we can do is that at least try to keep them outdoors. But for cats, even if you keep them outdoors, the allergen will be there. And even if you remove the cat from the home, the allergen will be there for at least 2 to 3 months. So allergenicity wise, cats are more allergenic when compared with dogs.
Correct. Okay. Yeah.
We have one more question. Dr. Sarthak wants to know, says he has a 5-year-old child with severe persistent allergic rhinitis since last 3 to 4 months and also having a large size tonsils, kissing tonsils. Patient was advised intranasal mometasone, but any role of adenotonsillectomy depending on the size of the tonsil.
So, Soumya, you're taking that question, or
No, you can please answer. No.
So depending upon how well the patient responds to your treatment. So you have said that the child has been started on intranasal steroids. So after 2 months or 3 months, suppose the patient is having a very good symptomatic relief. That is, you have started the patient on mouth breathing or snoring. If it has decreased, then you can wait a little bit. Otherwise, you have done the nasal endoscopy. It depends upon how far the obstruction is there. It is like 1/3 obstruction, half the obstruction, or 3/4 obstruction. Anything which is more than 3/4 obstruction, that is around 75 to 80%, and is not responding to your intranasal steroid, it is always better to go for a surgery. Even though there are some controversies between pediatric practitioners, allergists, and ENT surgeons on this, but if the child is not responding to intranasal steroids after a few months, better to go for surgery.
All right. Okay. Dr. Priya Shirley wants to know regarding the exposure to pets during pregnancy and early infancy. So does allergy reduce with early exposure?
Can I take that question?
Yes, please.
So, very important question raised by Dr. Priya. I think there is a very good level of evidence which shows that early exposure to pets during pregnancy or early childhood is actually, in fact, protective against development of allergies. But once you are allergic, you have to remove the pets. That's all it is. As sir was telling, which is the major challenge in our clinical practice. But early life exposure, generally, I think that is why I think initially when we were all rural backgrounds, we see less of allergies, urban background where the pet exposure is not seen early and more sterile environment. That's where we see more of allergic etiologies being happening.
Yeah. If there are no more questions, anybody wants to tell anything more?
Ravi, Dr. Kalapnor here.
Yeah, Kalapa, yeah, please.
Hello, sir. Good evening, sir.
Sorry, I missed you. Please.
Good evening,
Most
sir.
welcome,
Good evening,
Kalapa.
sir.
Thank you for joining. Please.
Good evening.
Yeah.
Krishnam,
Hi, sir. Good evening, sir.
good evening. Good evening.
Good evening, Dr.
was-
Kalapana, sir. Thank you for joining.
Yeah, Hema ma'am. Yeah, I went through. I attended all the cases. It was really nice.
And there is
Thank you,
one
sir.
very beautiful book written by Kalpana sir on allergens alone, indoor and outdoor allergens alone. Is it still available there, sir, in these things?
Yeah.
It's a very good book.
I just wanted to congratulate both of you, those who presented, especially Soumya and Dr. Hema, and they did extremely well and make sure that day-to-day issues are addressed. And as usual, Krishna Mohan has, narrated very well. Only one, just one, the submission here. There was one question asking about LTRA in case of adenoidal hypertrophy, if I'm right.
Yes.
So the AAP, American Academy of Pediatrics, still recommends LTRA, but evidence is not that high. But definitely they say that you can use it for 3 months. So 40% of children do respond for LTRA alone with the nasal steroids, intranasal steroids with LTRA. But there are studies wherein even isolated or the drug alone, LTRA can be given for adenoidal hypertrophy. So that is what I just thought I will share with you all. That is one thing is available in even it is given in textbook of respiratory AAP textbook of pediatric respiratory. So that is one thing is there. And very interesting to know that whenever there is a severe allergic rhinitis with conjunctivitis, it's a real challenge to the practicing allergists.
Correct.
Correct,
really.
Yeah, it is. It sounds very easy to discuss about it, but when case comes, it's difficult to treat. Very difficult to treat, and majority of the time it will be if it is a multiple allergen sensitivity. Usually, we will lose the battle.
Correct. Absolutely. Especially in that case, really blindness was there, something unable to see. Soumya was really handled it very nicely, the second case.
No, of course. What happens is, if you know the clear-cut allergen, the majority of the time your immunotherapy will help to a great extent. But if it is polyallergen, then the challenge comes. If we don't have too many armamentarium in our this thing, then they were very difficult to treat.
Correct. So before Shruti concludes, in the beginning, I should have acknowledged the presence of so many people were there because of the lack of time and other things. I could not do it. So I'm sorry for that one. Dr. Sanjeev Joshi, President IAP Maharashtra, was thank you for joining. Dr. S.T. Sethi, EB member, Dr. Priya Shivalli, Dr. Sahana Devdas, and Kalapa. Now I recognize him. He was there, but I could not. So I'm sorry. Thank you for joining the meeting. Dr. Jayashree Deshpande, President 2025 IAP Palghar branch. He was there. Thank you, Madam, joining. IAP Bangalore Secretary, Dr. Sunil Kumar. Sorry, once again, we missed you. Thank you for joining. Dr. Baswantappa, HOD, Medical College, Chitradurga. And my good friend, Dr. Satish Agarwal, who is the chairperson of Environ chapter for the 2026. He was there. And my very good friend, Dr. Thiru from Pondicherry, EB member 2020 was there. Dr. Pahla, Dr. Raju Katke, and Dr. Ramesh Bajania, the previous vice president, was there. Sorry, I missed all of you. Plus, thank you for all of you for joining here. Dr. Manoj Raval, EB member Haryana, Dr. Satish Sharma, and medical legal chairperson, Dr. Panchaksharaya and Dr. Kalapa is there. And Dr. Sushma Chaitani, EB member from Goa, all were there. And Dr. Rashmin Cecil, EB member 26 Gujarat, Dr. Sangeeta Lora, and Dr. Yogesh Parekh. For all of you who were there, thank you for joining it. We are all happy that you joined and listened to our thing. Now over to Dr. Shruti and Dr. Kushal.
Thank
you very much, sir. Continue, Shruti. Continue.
Thank you, everyone. Thank you, Thanks to our chief guest, to our expert, and to our esteemed speakers for making the session such an interesting and very useful one for each one of us in our OPD practice. Thank you very, very much, and thank you for the enthusiastic discussion that we have had. I'd like to hand it over to Dr. Kushar.
Thank you, Dr. Suthi. I thank all my IAP members, and I thank the speakers for the day.